Doctors, let us move on to discuss the control mechanisms of ventilation. Respiratory events are being controlled by two different sets of mechanism. One is chemical kind of regulation and the second one is neural regulation. Chemical regulation happens with chemoreceptors. Neural regulation happens with neurons that are located essentially in medulla oblongata. With this brief introduction, let us move on to take up chemical regulation of respiration first. As I just told you, doctors, we have receptors that senses changes in blood. Now that changes essentially includes oxygen tension, carbon dioxide levels and acidic levels in blood. So these receptors which are sensitive to changes in oxygen tension, carbon dioxide tension and pH of blood are called as chemoreceptors. We have chemoreceptors located at two regions. Number one is peripheral chemoreceptors, which as I just told you senses oxygen levels, carbon dioxide level and pH level of arterial blood. And we have central chemoreceptors which senses hydrogen ion concentration, in another word senses pH of cerebrospinal fluid. As central chemoreceptors are located in medulla oblongata and those regions are well covered by blood-brain barrier, chemical changes in blood do not able to influence activities in central chemoreceptors. Whereas, since these regions are completely surrounded by cerebrospinal fluid, any chemical changes in cerebrospinal fluid, especially and in particular, number one, the pH of cerebrospinal fluid, and number two, carbon dioxide content of cerebrospinal fluid is going to trigger central chemoreceptors, doctors. So let us take up peripheral chemoreceptors first. Peripheral chemoreceptors are located in two regions. Number one, at carotid bodies. Number two, aortic arch. Carotid body peripheral chemoreceptors are located primarily in the junction between external and internal carotid arteries. So let us take this as external carotid artery and the second one as internal carotid artery. Now we do have peripheral chemoreceptors which are located at the junction between external and internal carotid arteries, doctors. Now this region is called as carotid sinus, where we have the carotid bodies located. Now carotid body do receive their blood supply primarily from external carotid arteries. The blood that goes from common carotid into external carotid artery is the one that is going to perfuse the peripheral chemoreceptors located in carotid bodies. So point number one, we have carotid bodies located at the junction of external and internal carotid artery. And coming to the second one, aortic arch, we have arch of aorta, where we do have the same kind of peripheral chemoreceptors. Now, considerably speaking, aortic arch or aortic chemoreceptors do not have any major role in controlling respiratory pattern. Although they do have a lesser role, their contribution to regulation of respiration even during normal levels as well as during hypercapnic levels are not very much. So we can practically ignore the presence of aortic arch chemoreceptors. So let us focus our knowledge towards the peripheral chemoreceptors located on carotid bodies. So doctors, carotid bodies are innervated by glossopharyngeal nerve, ninth cranial nerve, which carries afferent information to a region called as nucleus tractus solitarius. Now if we could able to get into the cells of carotid bodies, we could able to find two kinds of cells here. Type 1 cell, also called as glomus cells. Type 2 cells, also called as sheath cells. Now, sheath cells are again also called as sustentacular cells, but don't worry about the terminologies. You don't have to worry a bit about type 2 cells because they are not innervated. They do not play any role in chemoreception. So, all our focus are going to be on type 1 chemoreceptor cells, doctors, which are glomus cells. Now, these cells, type 1 cell, on their membrane do have an oxygen sensitive potassium channel. On glomus cells, we do have a potassium channel which is an oxygen sensitive potassium channels. So, what happens is whenever there is hypoxia, that is decreased partial pressure of oxygen less than 60 millimeters of mercury, this makes the hypoxic environment closes the gates of oxygen sensitive potassium channel. So, during hypoxia, oxygen sensitive potassium channel gets closed. Because they get closed during hypoxia, potassium will not able to move out. You know very well, the natural concentration gradient of potassium favors potassium to move out of the cell, isn't it, doctors? Now, as this channel is being closed, the tendency of potassium to efflux out has been arrested. With this happening, potassium gets accumulated within the cell. As potassium keeps getting stuck within the cell, this leads to increased intracellular potassium and increased cationic concentration inside a cell leads to depolarization. As the cell gets depolarized, action potential is getting generated, which is being conveyed to glossopharyngeal nerve, and glossopharyngeal nerve takes this afferent to nucleus tractus solitarius, doctors. So, that is how point number 1, hypoxia, the most important trigger for peripheral chemoreceptor cells, is going to activate a peripheral chemoreceptor, thereby the afferent is going to transfer to nucleus tractus solitarius. Right, people? So, this is how type 1 cells or glomus cells of a peripheral chemoreceptor functions. Now, if you look at the triggering factors for these peripheral chemoreceptors, let us see the triggering factors in a sequence here. The most important triggering factor is number 1, hypoxia with a partial pressure of oxygen. Now, remember, doctors, this is an arterial blood, isn't it? Carotid artery carries arterial blood. So, when we speak about partial pressure, we should be clear about arterial partial pressure. The partial pressure of oxygen in arterial blood should fall to a value of less than 60 millimeters of mercury for effective activation of glomus cell. Point number 1. Point number 2, hypercapnia, increased partial pressure of carbon dioxide. Arterial carbon dioxide more than 40 millimeters of mercury. Normal arterial carbon dioxide level is 40 millimeters of mercury, doctors. Whenever the carbon dioxide level increases more than 40 millimeters of mercury in arterial blood, it will instantaneously trigger peripheral chemoreceptors. And the third trigger for a peripheral chemoreceptor is pH, as it is falling less than 7.35. As the blood pH is turning acidic, peripheral chemoreceptors are getting activated, doctors. Now, I want you to be clear about these 3 points. So, the most important trigger is hypoxia. The most important trigger for a peripheral chemoreceptor is hypoxia, especially when the partial pressure of oxygen is falling less than 60 millimeters of mercury. So, if your question gives you all the 3 choices as options, hypoxia, hypercapnia, acidosis, you must pick hypoxia as the most important trigger for a peripheral chemoreceptor. Now, you guys know that arterial partial pressure of oxygen is about 98 millimeters of mercury, right? But what level is it taking for activating a peripheral chemoreceptor? The partial pressure should fall to a value of about 60 millimeters of mercury, isn't it? But when you consider carbon dioxide, the normal carbon dioxide partial pressure itself is 40 millimeters of mercury. So when there is a slight fall, even a little fall in partial pressure of carbon dioxide will do elicit an excitatory response from chemoreceptors. So naturally it appears that carbon dioxide do have a better excitatory role, isn't it, doctors? But here you have to be very careful. Let us consider what happens when hypercapnia gets manifested in body. Remember, doctors, with hypercapnia, if you look at the response curve for hypercapnia, we do have the most prominent response coming from central chemoreceptors. Response to a hypercapnia comes primarily from central chemoreceptor, about 70% of response. About 70% of response to hypercapnia comes from central chemoreceptors. Very important. So, if the question is asked in the other way, the receptor which senses hypercapnia and contributes to a major role in regulating hypercapnia is central chemoreceptors. What is the role of peripheral chemoreceptors then? Peripheral chemoreceptors just contributes to 30% of response. Remember, peripheral chemoreceptors contributes to just 30% of the response, doctors. On the other hand, central chemoreceptors are not able to sense oxygen content. So hypoxia and its subsequent responses will be primarily mediated in the complete way by peripheral chemoreceptors. Okay, people? So the response for hypercapnia comes primarily from central chemoreceptors and secondarily from peripheral chemoreceptors. Whereas the response for hypoxia comes only from peripheral chemoreceptors. Right, doctors? This is point number 1 when it comes to hypercapnia as well as hypoxia. You must remember. Now, the second point in peripheral chemoreceptors is for a normal ventilation. For normal ventilatory control, peripheral chemoreceptors contributes to just 15%. That's all. Normal ventilatory control, just 15% of normal day-to-day breathing is being controlled by or is being influenced by peripheral chemoreceptors, doctors. So these values you have to be familiar with peripheral chemoreceptors. Let us summarize all these points. Point number 1, peripheral chemoreceptors do have two kinds of location. Number 1 in carotid body, number 2 in aortic arch. As the contribution of aortic arch is extremely negligible, you can practically ignore it and stay focused on the peripheral chemoreceptors located on carotid bodies. Now, the carotid bodies are innervated by glossopharyngeal nerve. The chemoreceptors in carotid body do have two kinds of cells, type 1, type 2 cells, out of which type 2 cells do not have any innervation. Type 1 cells are innervated by the glossopharyngeal nerve. They do have oxygen sensitive potassium channel which gets closed during hypoxia. This leads to depolarization of type 1 cell, producing an action potential in glossopharyngeal nerve. Thereby the information is conveyed to nucleus tractus solitarius. If you look at the trigger for a peripheral chemoreceptor, the most important trigger is hypoxia, followed by hypercapnia, followed by acidosis. Now, when it comes to hypercapnia, the primary control response comes from central chemoreceptors and secondarily just 15-30% of hypercapnic regulation is being contributed by peripheral chemoreceptors. So, central chemoreceptors 70, peripheral chemoreceptors 30. That's it. When it comes to hypoxia, central chemoreceptors have got no role while peripheral chemoreceptors are the exclusive centers involving in managing hypoxia, doctors. That's it. Now, the last point, for a normal ventilatory control, the contribution of a peripheral chemoreceptor is just 15%. That's all. Let us move on to central chemoreceptors. Two points I want you to be familiar with, and just this is to avoid confusions, doctors. Now, traditionally and with the old school of textbooks, we do have the evidence based location of central chemoreceptors in rostral, ventral, medulla. The location of central chemoreceptor is rostral, ventral, medulla. As of the evidences we do have, and that has been published in textbooks. But with recent journals and articles, we are getting more than 15 centers in brain that do have an ability to involve in central chemoreception. That includes dorsal respiratory group, ventral respiratory group of nucleuses, certain group of nucleus even located in spinal cord, and we do have certain group of nucleuses located in hypothalamus, cerebellum. So on an average we do have 15 groups of nucleus, doctors. But as of now, we do have the textbooks which are considered as the Bible for entrance exams do still comes with the same solid evidence that the prime location of central chemoreceptors is rostral, ventral, medulla. So in order to avoid confusion and not to get stuck with out of subject context and all, let us be very realistic here. The region for central chemoreceptor is rostral, ventral, medulla. Now, my dear friends, if the question gives you certain other regions, dorsal group of nucleus, ventral group of nucleus, or if the question comes about the numbers of centers which controls central chemoreception, please remember it is not just one. We do have more than one centers, right? On an average, we have evidences coming up with 15 or about centers, doctors. So this point I want you to be very clear with. Okay, so it is not just one, we do have 15 regions, and the regions includes hypothalamus, cerebellum, some part in spinal cord, some part in dorsal medulla. We do have ventral respiratory group of nucleus and those neurons in dorsal respiratory group. So these are all the other regions which are involved in central chemoreception. Certain points you need to be familiar for your PG entrance exam. Point number 1, all these receptors are surrounded by blood-brain barrier. So any changes in blood levels, anything which is getting altered in blood is not going to influence neurons. Okay, so let us consider the intervening structure as blood-brain barrier. We do have cerebral vasculature, and let us take up a neuron which belongs to central chemoreceptor, and we do have cerebrospinal fluid surrounding these neurons. The fluid represents cerebrospinal fluid. So what happens is, whenever there is going to be an increased partial pressure of arterial carbon dioxide being a gas can very well diffuse across the cell membrane. Okay, carbon dioxide diffuse across the vasculature, goes to the interstitial space, and being a gas, carbon dioxide has got a tremendous solubility when compared with oxygen. Because of its increased solubility, carbon dioxide comfortably gets diffused across blood-brain barrier also. And carbon dioxide comes to cerebrospinal fluid. In cerebrospinal fluid, carbon dioxide is going to combine with water of cerebrospinal fluid. In the presence of enzyme carbonic anhydrase, they form carbonic acid which gets split into H plus ion and bicarbonate. Now the hydrogen ion that has been formed, the hydrogen ion that has been formed by splitting of carbonic acid in cerebrospinal fluid is going to trigger. This hydrogen ion is going to trigger this neuron, and this leads to changes in respiratory pattern. So ultimately speaking, the triggering factor for a central chemoreceptor is number 1, H plus ion in CSF. Increased concentration of hydrogen ion in CSF can also be called as reduction in pH of cerebrospinal fluid. Number 2, presence of carbon dioxide in CSF also will trigger the neurons of central chemoreceptors, doctors. Right? This is all about our chemical regulation of respiration. Moving on to neural regulation of respiration. We have two regions primarily. Number 1, pons. Number 2, medulla oblongata. Now pons do have two centers, doctors. Upper pons do have a center. See, it's dual, okay? It's binary, it is not just one. On one side of pons and medulla, we do have a respiratory group of nucleases, and on the other side, we do have a similar kind of respiratory group of nucleases. Now, let me just stick to one side of the brainstem in order to avoid confusions with the diagram, okay? So, we have the center located at the upper pons named as pneumotaxic center. And we have another center located at lower pons called as apneustic center. On medulla oblongata, we do have dorsal respiratory group of neurons, doctors, which are primarily concerned with inspiration. Dorsal respiratory group of neurons are exclusively concerned with inspiration. I am marking this with letter I. We do have a similar group of nucleus in the medulla, and that is called as ventral respiratory group. Ventral respiratory group of nucleus. Now, ventral respiratory group of nucleus is quite peculiar in nature that it do have a region that is going to influence inspiration, just like the dorsal respiratory group. In ventral respiratory group, we do have a particular region concerned with inspiration, and that region is called as pre-Botzinger complex. Pre-Botzinger complex is the pacemaker of respiration, doctors. I think that's a very fundamental point you must be remembering. So, pre-Botzinger complex is the pacemaker of respiration. Ventral respiratory group also do have regions which are concerned with expiration. They also do have region which are concerned with expiration, doctors. So, this is how the centers that are involved in controlling respiration are arranged in brainstem. Now, if you look at the afferents these centers receives, okay, both pons as well as medulla send their afferents to cerebral cortex. In turn, cerebral cortex produces efferent connections over both pons as well as medulla. You do have efferents coming from cerebral cortex going to pons and medulla. Now, when it comes to the efferent, doctors, along with cerebral cortex, we do have other regions that contributing efferent connections to respiratory center, and they are hypothalamus, limbic system, and efferents also comes from thalamus, right? So, when it comes to the efferent connections that goes to respiratory controlling neurons, we have primary efferents coming from cerebral cortex, motor cortex, sensory cortex, and we have efferents coming from hypothalamus, limbic system as well as from thalamus, doctors. Together, all these efferents involving respiratory control, okay, all these efferents involving respiratory control are together called as central pattern generator. Central pattern generator. Now, respiratory rhythm, the volumes with which air gets in and out of the lungs, the tidal volume, everything are all determined by this central respiratory group. So respiratory expansion, the expansion of lungs, expansion of thorax are all mediated exclusively by the central respiratory pattern generator, doctors, which is exactly why we breathe different at different circumstances. When we are laughing, our breath will be different. When we are sad, when we are crying, our breath will be different. When we are at extreme of joy, extreme of happiness, we will be breathing differently. When we are at the other end of emotions, extremely depressed or sad, we do have other kind of breathing. So our mood, our motor activities, our sensory experiences are all going to influence the way with which our breathing changes, right friends? So this influence of higher regions over the respiratory centers located in medulla and pons, the complete network is called as central pattern generator, right friends? So we have apneustic center, pneumotaxic center located in pons, and we have medullary nucleus group, dorsal and ventral respiratory group of nucleus, doctors. Fine, let us move on to discuss about the connections coming from peripheral receptors. So we do have number one, central chemoreceptor. Central chemoreceptor is going to trigger inspiratory neurons on one hand. On the other hand, apneustic center is also going to trigger inspiratory neurons. Apneustic center is also going to trigger inspiratory neurons. But the influence of apneustic center over inspiratory neurons will be so tremendous that the excitation will happen in a very significant way. The activation will be of so much of magnitude that apneustic center overactivity will literally makes the person to stay in apneusis, right doctors, which is why the name, it is because the influence of apneustic center on inspiratory neurons are so tremendous, right? On the other hand, we have peripheral chemoreceptors which again influences inspiratory neurons, peripheral chemoreceptors. Along with these chemoreceptors, doctors, okay, we just discussed central chemoreceptors and peripheral chemoreceptors. We have certain other receptors that is especially involved in sensing stretch of the lungs. They are called as pulmonary stretch receptors. Now, pulmonary stretch receptor senses expansion of airways. They are located in smooth muscles and epithelium of airways. When they sense extreme stretch of airways, they in turn produces a inhibitory efferent, and this inhibitory efferent goes to apneustic center, inhibiting apneustic center, as well as they go and inhibit inspiratory neurons. Okay, when pulmonary stretch receptor senses extreme stretch of airways, in turn lung, because of the over distension and hyperinflation, these receptor gets activated. As a consequence, inhibitory impulses starts from those receptor and comes to apneustic center and inspiratory group of neurons. Thereby, stretch receptors tries to suppress inspiration. The nerve that carries these impulses are primarily vagus nerve, 10th cranial nerve, that is vagus. Now, if you look at the inspiratory group of neurons, they are getting tremendously stimulated by multiple sources, doctors. Okay, we have inspiratory neurons excitation coming from apneustic center, coming from central chemoreceptors, coming from peripheral chemoreceptors. Because these inspiratory neurons are being stimulated by multiple centers, pneumotaxic center makes sure the stimulation happens in a normal level. So to bring this excitation to a normal level, pneumotaxic center literally inhibits apneustic center. Pneumotaxic center in upper pons inhibits apneustic center. When apneustic centers are being inhibited, right friends, when apneustic centers are getting inhibited by pneumotaxic center, the effect of apneustic center over inspiratory neurons will be much lessened. Thereby, this leads to the inspiratory neurons getting excited in a normal level, and a normal breathing happens with a tidal volume of 500 ml. This is how the respiratory pattern is being manifested, doctors. Now, 2 points, just 2 points you have to remember here. Let us take up point number 1, that is a case with mid-Pontine transaction. Let us consider a case with mid-Pontine transaction. See, ponds, as I told you, you do have two regions, so upper ponds and lower ponds. Upper ponds having pneumotaxic center, lower ponds having apneustic center. When there happens to be a transaction at this level, when there is a transaction at mid-Pontine level, the ability of pneumotaxic center to control apneustic center is lost. This leads to overactive apneustic center. So, thereby the subject will have a tremendous inspiratory ramp. Because apneustic center are uncontrolled, they go and activate inspiratory neurons in a huge magnitude. The subject will have a heavy inspiratory ramp, and because of a hyperinflation seen by the stretch receptors of lungs. Okay. For example, because of overinflation of lung, which is being in turn sensed by receptors located in airway smooth muscles and epithelium, we do have activation of pulmonary stretch receptors now. Pulmonary stretch receptor gets activated because of overinflation, that in turn through vagus nerve tries to inhibit apneustic center. Because apneustic center is getting inhibited, the subject will go for expiration. So, instead of a normal breathing, my dear friends, consider this is a normal tidal breathing. If a normal tidal breathing is somewhat like this, with each breath carrying up to 500 ml of air. When it comes to apneustic breathing, the subject will have a heavy and prolonged inspiratory ramp followed by expiration. Again a heavy prolonged inspiratory ramp followed by expiration. So much will be the magnitude of air entry into the lungs, doctors. So, this is what is getting manifested in mid-Pontine transaction. Apneusis is seen in mid-Pontine transaction. Point number 1. Fine, people. Now, let us explain, or let us try to see what happens in this pathology and how someone could able to expirate. Okay. The only reason with which the subject can able to expirate is by pulmonary stretch receptors that inhibits apneustic center, thereby expiration takes place. Now, remember, my dear friends, when along with mid-Pontine transaction, if there happens to be a damage to vagus also, if there is a damage to vagus also, the inspiratory ramp and the overinflation of lung, even though it is being sensed by pulmonary stretch receptor, it will not be used as an action potential to inhibit apneustic center, because the action potential has to travel through vagus nerve. In this case, vagus is also being damaged. With the damage to vagus and the mid-Pontine transaction, we do have uncontrolled, uninhibited apneustic center that keeps on activating inspiratory neurons, leading to a very significant prolonged inspiratory spasm culminating in death. Right, doctors? So, when there is mid-Pontine transaction along with vagal damage, mid-Pontine transaction plus bilateral vagal damage, the subject cannot able to breathe out and expire. This leads to death, doctors. So, point number 2, mid-Pontine transaction along with bilateral vagotomy leads to death, doctors. Right. So, these are the clinical scenarios where brainstem damages are happening. Right, people? With particular level of lesions, we do have difference in manifestation of respiration. With simple mid-Pontine transaction alone, there will be apneusis, but the subject could still be alive. Whereas, with damage of vagus along with mid-Pontine transaction, the subject cannot able to breathe out. Exhalation is impossible. The subject dies at the height of inspiration. Right, people? So, this is respiratory control by neural mechanism. So, this completes our regulation of respiration. Now with this basics, let us move on to see the abnormal respiratory patterns, doctors. When it comes to abnormal respiratory pattern, you have to be familiar with two kinds of breathing. Number one, Kane-Stokes breathing and Kussmaul's breathing. So let us take up Kane-Stokes here. Few points in Kane-Stokes breathing. Here, let us take up a normal breathing pattern. We have a normal inspiration, normal expiration. If you watch closely, there is going to be a inspiration followed by a small pause and expiration, inspiration followed by a small pause and expiration. That is how it goes on, doctors. And the volume happens to be 500 ml, normal tidal breathing, when the subject is at rest. During Kane-Stokes, we do have a gradual increase in the depth of breathing. So the subject will have a very gradual increase in depth of breathing. So the minute ventilation gradually increases to reach a peak, and then there is going to be a gradual decline in the tidal ventilation and volume affair that has been taken in. Once the respiratory movement reaches the minimum possible limit, it goes for an apnea. For a period of some 10 to 15 seconds, there will be a phase of apnea, which is again followed by a gradual increment in magnitude of breathing, doctors. So the whole cycle repeats. There is going to be a crescendo decrescendo pattern of depth of respiration. So this gradual increase in tidal volume and leading to a peak followed by a gradual reduction in tidal volume ending up in apnea. This kind of breathing is called as Kane-Stokes breathing. Now where do you see Kane-Stokes breathing, doctors? The most important differential diagnosis for Kane-Stokes breathing is congestive heart failure. Now because of heart failure, there is going to be a reduction in ejection. This reduced ejection leads to gradually less cerebral blood flow. When cerebral blood flow becomes lesser, there is going to be a decreased perfusion of respiratory centers, leading to gradual accumulation of hypercapnia. Now, because respiratory centers, doctors, are being inhibited because of decreased perfusion to respiratory centers, this reduced perfusion leads to decreased respiratory activity, which is why the respiratory pattern flows. It comes to a very progressively declining state. So the respiratory activity gradually decreases, culminating in apnea. With apnea, there is going to be accumulation of carbon dioxide leading to hypercapnia. So the accumulated carbon dioxide, because of hypercapnia, this triggers respiratory center. So gradually there will be a increase in amplitude of respiratory movements. So with increased amplitude, for some moment induced by hypercapnia, this hypercapnia will be washed out, isn't it? So this leads to carbon dioxide washout. As carbon dioxide washout happens, the trigger to activate respiratory centers is being taken off. With the trigger is being lost, there will be a gradual reduction. There will be a gradual reduction in amplitude of respiration. So this phase keeps on happening, and this is exactly because of reduction in cerebral blood flow, doctors, seen in heart failure conditions. So Kane-Stokes breathing is a very important clinical finding, and that is a very crisp clinical finding to say about heart failure. Okay. So the first point that should strike your brain when we see a question on Kane-Stokes breathing is a differential diagnosis of a congestive heart failure. So what else can manifest with this kind of Kane-Stokes breathing? So other conditions that leads to reduced cerebral blood flow. like tumors in brain, masses compressing blood vessels that goes to perfusing respiratory centers, or any infectious disorders, any localized vasoconstriction. Wherever we experience a reduction in cerebral blood flow, this will lead to Cheyne-Stokes breathing. So, other causes of reduction in cerebral blood flow should be evaluated for Cheyne-Stokes breathing, doctors. Now, is it absolutely abnormal Cheyne-Stokes breathing? No, not at all. There are certain conditions where Cheyne-Stokes breathing is seen in normal individuals too. Who are all the patients, who are all the subjects, normal subjects manifesting Cheyne-Stokes breathing? Number one, infants. Infants and newborn, doctors. Infants and newborn do experience a normal spell of Cheyne-Stokes breathing. There will be a gradual increase in amplitude of breathing, gradual decline in amplitude of breathing followed by apnea. This will be seen in newborns, infants and newborns, doctors. Number two, old age individuals. Both in geriatric as well as pediatric population, Cheyne-Stokes breathing is normal, can be normally seen. It has to be again rolled out, my dear friends. Please be very clear there. Okay. Now, apart from infants and geriatric population, we do have certain group of people who experience Cheyne-Stokes kind of breathing at high altitude. So, for some group of people in high altitude, Cheyne-Stokes breathing can be a normal phenomena. It doesn't indicate, or it is not a reflection of any underlying pathophysiology. So, Cheyne-Stokes breathing is not absolutely abnormal, doctors. We have three kinds of people who manifest Cheyne-Stokes breathing at normal physiological level itself, right? So, this is Cheyne-Stokes breathing. Remember, you got a crescendo decrescendo pattern of respiratory amplitude followed by apnea, and the whole cycle continues. Second point, it must be correlated with congestive heart failure, reduction in cerebral blood flow. Point number two. Point number three, in which condition it is normal in infants and newborn, in geriatric population, for certain people living in high altitude, doctors. Good. That is Cheyne-Stokes. Moving on to Kussmaul's breathing. Let us take up normal breathing first. As we just discussed, we have a inspiration followed by a pause, expiration, inspiration followed by a pause and expiration, inspiration, a pause and expiration. So, such a kind of movements will be seen in normal limits with a tidal volume of 500 ml. Whereas in Kussmaul's breathing, what happens is we have an increase in rate of inspiration as well as depth of inspiration. A panting kind of breathing without any pauses. A panting kind of breathing without any pauses. Right? So, what are all the features here? There is going to be increased rate of breathing, increased depth of breathing. Increased rate alone is called as tachypnea. Increased depth is called as hyperventilation. Don't get distracted with the words, doctors. When your question speaks about tachypnea, it means the rate of respiration alone is increased. When it is also including the word hyperventilation, it speaks about depth of ventilation. So, Kussmaul's breathing is more of a hyperventilation and not a tachypnea. Okay. So, this is more of a hyperventilation and not mere tachypnea. So, point number 1 and 2, increased rate as well as increased depth. Point number 3, there is no pause between inspiration and expiration. There is no pause between inspiration and expiration, doctors. Right? So, this is Kussmaul's breathing. And where do you have Kussmaul's breathing manifested with? In case of acidosis, especially when there is metabolic acidosis with pH less than 7.35, there is going to be activation of peripheral chemoreceptors, and this triggers inspiratory centers leading to Kussmaul's breathing. So, it is all due to acidosis induced hyperventilation. This is seen in diabetic ketoacidosis, this is seen in uremic acidosis. All kinds of metabolic acidosis will produce Kussmaul's breathing doctors. Okay, so these are all the abnormal breathing pattern you have to be very clear about. One is Kane-Stokes and the second one is Kussmaul's breathing. Kane-Stokes is seen in congestive heart failure, Kussmaul's is seen in metabolic acidotic conditions, right? So this completes our regulation of respiration and abnormal breathing movements. Thank you.